Madam Chair and subcommittee and committee members, thank you for the opportunity to speak in support of House Bill 4278. I've been a CRNA since 2008, and the Army brought me to South Carolina. Fort Jackson was my first duty station as a CRNA, where myself and my CRNA colleagues provided anesthesia services to soldiers, retirees, and their family members. And that included the preoperative preparation of the patient, it included the intraoperative care, and the postoperative concerns that patients, in order for patients to go home safely and do well after their operation. We provided all those services without physician supervision and without an anesthesiologist. Dr. Estep covered the arbitrariness of the signature required on the nurse's the advanced practice nurse application, so I'm not going to belabor that point. But the signature that I had to get, I could only get because I happened to know a surgeon who was in the Army and licensed in South Carolina, and it was completely arbitrary. That physician supervision language in the Nurse Practice Act creates a barrier to licensure, and it makes it really difficult to bring CRNAs into the state of South Carolina when you can't get a license without knowing a South Carolina physician. And what purpose is served by having that physician sign a license? Each CRNA, when they go to work in a place, is credentialed. Their education, certification, and work history is extensively investigated and validated. So that signature provides no additional assurance that you're safe to practice. To address the research that's presented, Cochrane summarizes research findings so people who make important healthcare policies, such as yourselves, have unbiased information to make difficult decisions without having to read them all. They are internationally recognized as the highest standard in healthcare research. In 2014, Cochrane did a review, which included 1.5 million patients, on whether it's better to have an anesthesiologist or a nurse anesthetist perform anesthesia. They concluded that no definitive statement can be made about the possible superiority of anesthesiologists over CRNAs. Regarding the patient care team, anesthesia is a referral service and it doesn't happen in a vacuum. Physicians, such as surgeons and other proceduralists, are always part of the team when a patient is undergoing a procedure requiring anesthesia. To insinuate that CRNAs, surgeons, and other members of the patient care team don't work closely together is shamefully misleading. Surgeons and operating practitioners should not supervise anesthesia. I think Dr. Estep mentioned what happens when people die when that happens. They must stay focused on the procedure. They rely on CRNAs, who are anesthesia experts, to keep patients safe and comfortable before, during, and after the procedure. CRNAs are trained using the same textbooks, the same equipment, and the same drugs as those used by anesthesiologists. And we're also held to the same standards of care in a court of law. Supervision language in the Nurse Practice Act implies control of the actions of the CRNA by the operating practitioner that does not exist in the real world.
3 minutes.
It creates the misconception we're not able to do anesthesia within the full scope of practice and implies that the surgeon is liable. I ask you to support this bill so that the law will reflect actual practice. It will not mandate anything. It will simply allow each facility to choose the business model that works best for their organization and their patients. Thank you.
Thank you.
Questions? Oh, sorry.
I've got one question for you, Representative Cox.
Thank you, Madam Chair. What type of facility do you practice in?
I practice in multiple facilities. I practice in a large health system where I work in an anesthesia care team with an anesthesiologist. I work in physicians' offices. I work in a supervised setting where the anesthesiologist is just in the building, but not necessarily in the operating room at any point in time. And in the military, I worked fully independently.
Okay, so you operate under a current care team model?
We always work in a care team.
Always
work in a care team. Yes, you have your surgeon, you have your nurse anesthetist, you may have an anesthesiologist there, you may not, but you're always in a care team. Anytime you perform anesthesia, it's done in a care team.
So when you say you may have an anesthesiologist there, and I'm just trying to understand the practicality of this, I don't have a medical background.
Certainly.
So when you say sometimes you have an anesthesiologist there, sometimes you don't, I mean, what's the difference in that? Is that just the certain site you're on, or?
Exactly.
And if you can operate now without a anesthesiologist there, then what does this do? What does this bill do that you currently can't do, I guess?
Well, I think Ms. Dennis mentioned that the Nurse Practice Act hadn't been updated since 1976. I was 6 years old, and it doesn't reflect current practice. As I mentioned, physicians should not be supervising anesthesia while they're doing something else. I mean, that's preposterous to me. If you were in an operating room and you saw the relationship between a surgeon or a proceduralist and myself, the nurse anesthetist, and I think Dr. Estep talked about this as well, they're focused on what they're doing. They're not looking at the vital sign machine and saying, hey, do you need to treat that blood pressure? And as you mentioned, it's facility specific. Each facility chooses the model that they want to go with based on their patient's needs and the needs of the facility.
Okay, thank you.